Hi everyone, my name is Caitlin, and today I'll be presenting a case on community-acquired pneumonia that had a concern for PE in an older adult. This case stood out to me because what initially appeared as a straightforward respiratory infection quickly evolved into a patient requiring a much broader diagnostic approach. And as primary care providers, we frequently evaluate patients with cough and shortness of breath, but this case highlights the importance of resisting premature diagnostics, especially in older adults who can present atypically. Throughout the presentation, I'll discuss my diagnostic reasoning, the patient's history and physical, differential diagnosis, and the evidence-based plan. I'll also review the rationale for transferring the patient to the emergency department, current guideline recommendations for CAP, and the important role of the family nurse practitioner in coordinating transitions of care and preventing hospital readmissions. So I'd like to introduce Mrs. M, a 72-year-old retired school teacher who presented to our family medicine clinic for an acute same-day appointment. What immediately struck me about this patient was that despite her age, she was normally very active and completely independent. According to her daughter, she routinely walked about a mile every day, managed all her own activities of daily living, and had no baseline cognitive impairment. That baseline became very important because everything that brought her into the clinic represented a significant change from her usual level of function. Past medical history included hypertension, AFib managed with Eliquis, GERD, bilateral knee osteoarthritis, and a remote-provoked DVT following knee replacement surgery 8 years prior. Although the DVT was considered provoked, it immediately caught my attention because any prior thromboembolic event keeps PE on the differential when evaluating acute dyspnea and pleuritic chest pain. Socially, she lives independently with strong family support from her daughter who lives nearby. She's never smoked and denies alcohol or drug use, making chronic obstructive pulmonary disease less likely, while still recognizing that older adults remain at increased risk for community-acquired pneumonia regardless of their smoking history. Her immunization history was also relevant as she had received the PCV-15 approximately 2 years earlier and her annual influenza vaccine, but had not completed the recommended pneumococcal series and was overdue for her COVID-19 booster. As primary care providers, preventative care is an important part of our role. In this case, reinforced that need to address vaccination status once the patient's acute illness had resolved. Finally, one aspect of her medication history that required careful consideration was her reported penicillin allergy. She described only a childhood rash with no history of anaphylaxis or severe reaction. Current evidence suggests that many patients with remote, non-severe reactions are not truly allergic, making allergy clarification an important component of antibiotic stewardship and future treatment planning. When I first entered the room, the patient told me, "I've had a terrible cough for about 5 days, and now I'm short of breath just walking to the bathroom." That statement immediately prompted me to think beyond a typical routine upper respiratory infection. As I obtained her history, I learned that her illness had started approximately 5 days earlier with what she believed was a simple common cold. Initially, she stayed home, rested, increased her fluid intake, and tried over-the-counter cough medication without any improvement. Instead, gradual worsening, and her symptoms progressively got worse. Her cough became productive with thick yellow-green sputum, and she developed subjective fever, chills, right-sided chest pain that became noticeably worse with deep inspiration. Over the next several days, her shortness of breath progressed from occurring only during exertion to becoming present even with minimal activity. She also reported poor appetite and nausea, resulting in decreased oral intake over the previous 2 days. What concerned me most, however, was the information provided by her daughter. On the morning of presentation, she noticed that her mother appeared confused and unable to recall the date, which was completely out of character. Although the patient's mental status had improved somewhat by the time she arrived to the clinic, this acute change in cognition immediately raised my concern that her illness was more severe than a typical outpatient pneumonia. During the interview, I intentionally asked questions aimed at identifying other potentially life-threatening causes of her symptoms. She denied hemoptysis, unilateral leg swelling, calf pain, recent travel, prolonged immobilization, or recent hospitalization. While these negative findings lowered my suspicion for a pulmonary embolism, they did not eliminate it, particularly given her history of DVT and her current hypoxia. At this point of the encounter, community-acquired pneumonia had become my leading diagnosis, but I was careful not to anchor this too quickly, as her pleuritic chest pain, tachycardia, hypoxia, and previous event had me reminded that a PE remained a diagnosis that I could not afford to just miss. That mindset is what kind of shaped the remainder of my assessment and ultimately influenced the decision to transfer her to the emergency department for further evaluation. As I continued gathering the patient's history, the review of systems kind of helped to reinforce this decision. Constitutionally, she endured subjective fevers, chills, fatigue, decreased appetite, and generalized weakness over the past 5 days. She denied night sweats or recent weight loss, making chronic infection or a malignant process less likely. Her head, ears, eyes, nose, and throat review was largely unremarkable, denied sore throat, nasal congestion, rhinorrhea, ear pain, or sinus pressure. Aside from dry mouth, which was likely related to her decreased oral intake, there were few upper respiratory symptoms. This suggested that her illness was primarily involving the lower respiratory tract. Cardiovascular-wise, her review revealed right-sided pleuritic chest pain that worsened with deep inspiration. She denied palpitation, syncope, calf pain, or unilateral leg swelling. While these negative findings lowered my suspicion for DVT, I reminded myself that PE can still occur in the absence of classic extremity symptoms. Respiratory symptoms remained the most concerning aspect of her presentation, as she described a progressively worsening productive cough with yellow-green sputum, increasing shortness of breath, and pleuritic chest pain, and she specifically denied hemoptysis or wheezing. GI review was notable only for nausea and decreased oral intake. She denied vomiting, diarrhea, abdominal pain, or constipation. Genitourinary and musculoskeletal review were negative, making a UTI infection or another systemic source of infection less likely. Finally, the neurological review was particularly important. Although the patient denied headache, vocal weakness, dizziness, or sensory changes, her daughter reported an acute episode of confusion earlier that morning. And in older adults, altered mental status may be one of the earliest manifestations of a serious infection. And in the setting of suspected pneumonia, it is recognized as an indicator of increased disease severity. So at this point, my concern that this patient required a hospital-level care continued to grow. Before I even completed the physical examination, my overall impression was that this patient appeared significantly more ill than many patients we evaluate in the outpatient setting. She was mildly diaphoretic, appeared fatigued, and was visibly short of breath while speaking in complete sentences. Her vital signs immediately raised concern. She was febrile at 102 degrees, with a tachycardic with a heart rate of 108, mildly hypotensive at 102/58, and with a respiratory rate of 26 breaths per minute and an oxygen saturation of 91% on room air. Taken together, these findings suggested systemic infection with respiratory compromise. Cardiovascular examination demonstrated an irregular rhythm consistent with her known AFib. There were no murmurs, rubs, JVD distension, or peripheral edema. Although heart failure remained on my differential, the absence of volume overload made it less likely. The pulmonary examination provided the most important diagnostic clues. I appreciated decreased breath sounds over the right lower lung field, along with dullness to percussion in the same region. These findings strongly suggested focal consolidation rather than diffuse airway disease. Bilateral scattered bronchi further supported an infectious lower respiratory process. Her abdominal examination was benign, and her extremities showed no unilateral swelling, calf tenderness, or erythema. Again, although these findings reduced the likelihood of DVT, they did not completely eliminate PE from my differential. Neurologically, she was alert and cooperative, but oriented only to person in place, requiring prompting to identify the date. There is no focal neurological deficits, making an acute cerebrovascular event less likely. At this point in the encounter, the combination of hypoxia, abnormal lung findings, fever, and altered mental status strongly suggested that this patient was too ill to be managed safely outpatient. At this stage of the evaluation, community-acquired pneumonia became my leading diagnosis because it explained nearly every aspect of the patient's presentation. She had the classic combination of fever, productive cough, progressive dyspnea, pleuritic chest pain, and focal lung examination findings, consistent with right lower lobe consolidation. What further strengthened my suspicion was her hypoxia and acute change in mental status. In older adults, confusion may be one of the earliest indicators of severe pneumonia and is incorporated into validated severity assessment tools, such as the CURB-65 score. When I calculated her score, she received 1 point for confusion and 1 point for age greater than 65 years, placing her in a category where hospitalization should be strongly considered. Importantly, I avoided diagnosing pneumonia solely based on the presence of cough and fever. Instead, I integrated patient's history, physical examination, and overall clinical appearance. Her focal examination findings, systemic symptoms, and progressive respiratory decline created a clinical picture that was highly consistent with bacterial community-acquired pneumonia requiring inpatient evaluation and treatment. Although pneumonia remained my leading diagnosis, I made sure to challenge my initial impression by asking myself the important question of what diagnostic could be life-threatening if I failed to recognize it today. Pulmonary embolism immediately came to mind. Several aspects of her presentation, including pleuritic chest pain, hypoxia, tachycardia, and a history of DVT, could all be explained by an acute PE. At the same time, several findings argued against this diagnosis. She denied unilateral leg swelling, calf pain, recent immobilization, or hemoptysis, and she was already taking therapeutic Eliquis for AFib. While anticoagulation significantly lowers the likelihood of PE, it does not eliminate it entirely. Because PE carries potential fatal consequences if missed, I felt it remained essential to continue evaluating for this diagnosis with a hospital workup. Acute decompensated heart failure was another diagnostic I considered because dyspnea and hypoxia are common presenting symptoms in older adults. However, I continued synthesizing the clinical picture, and this became less likely. Although she was mildly tachycardic and short of breath, she lacked many of the classic findings associated with heart failure exacerbation. She denied orthopnea and paroxysmal nocturnal dyspnea and had no peripheral edema or JVD as distension. Her lung examination demonstrated focal consolidation rather than diffuse crackles, consistent with pulmonary edema. Additionally, her fever, chills, productive sputum, and pleuritic chest pain pointed much more strongly toward an infectious process. While heart failure remained on my differential until additional diagnostics could be obtained, it was not the diagnostic that best explained her presentation. Finally, I considered viral pneumonia, including COVID-19 and influenza, particularly because respiratory virus remains common causes of acute respiratory illness in older adults. Viral infection can certainly produce fever, cough, fatigue, and dyspnea. However, several findings made bacterial community-acquired pneumonia more likely. Her productive yellow-green sputum, localized physical exam findings, and evidence of right lower lobe consolidation were more consistent with a bacterial etiology. Nevertheless, viral testing remained appropriate because viral co-infection can occur and would influence isolation precautions and potential antiviral treatment. This differential reinforced an important principle in primary care. Even when one diagnosis appears most likely, we must remain systematic in our evaluation and continue to consider alternative explanations until sufficient evidence allows us to narrow our diagnosis confidently. At this point in the evaluation, I felt confident that community-acquired pneumonia was the patient's most likely diagnosis. However, because she was still in the outpatient clinic, my responsibility shifted from simply making the diagnosis to determining whether she could be managed safely outside the hospital. Several factors influenced that decision. First, she was hypoxic with an oxygen saturation of 91% on room air. Second, she demonstrated new confusion, which represented a significant departure from her baseline and is recognized as a marker of severe pneumonia in older adults. Third, she had poor oral intake, borderline hypotension, persistent tachycardia, and increased respiratory distress. Individually, each of these findings is concerning, but together they painted the picture of a patient at risk for clinical deterioration. I calculated her CURB 65 score, which was 2, based on her age and acute confusion. While clinical prediction tools should never replace clinical judgment, they can support decision-making and reinforce the need for escalation in a case. In this case, both the objective data and my overall impression indicated that outpatient treatment would not be appropriate. I therefore arranged EMS transport to the emergency department rather than having the patient travel by private vehicle. After transport, communication was handed off to the ER, and my leading diagnosis of community-acquired pneumonia was communicated, with my concern also for a PE, until definite imaging could exclude it. This case reinforced that as a family nurse practitioner, one of our most important responsibilities is recognizing when a patient has crossed the threshold from outpatient management to requiring higher acuity care. Once the decision was made to transfer the patient, I just considered what evidence-based management would likely occur upon arrival at the hospital, which I have decided to share. Current ATS and IDSA guidelines recommend obtaining chest imaging to confirm the diagnosis while beginning empiric antibiotic therapy promptly, as delays in treatment are associated with worse outcomes. Assuming imaging confirmed community-acquired pneumonia without risk factors, empiric therapy with IV ceftriaxone and azithromycin would be appropriate. Because her reported penicillin allergy consisted only of a childhood rash without features of an IgE-mediated reaction, ceftriaxone would generally remain an acceptable option after careful allergy clarification. This is an important example of antibiotic stewardship, as unnecessarily avoiding beta-lactam antibiotics can lead to broader spectrum therapy and increase adverse events and antimicrobial resistance. Supportive care would also play a significant role in her recovery. She would require supplemental oxygen to maintain adequate oxygen saturation, IV fluids to correct dehydration from poor oral intake, antipyretics for her fever management, and continuous monitoring of her respiratory and cardiovascular status. Medication reconciliation would also be essential, particularly because she takes Eliquis for AFib. Her anticoagulation status would need to be considered during any invasive procedures and while evaluating for pulmonary embolism. Another key aspect of management is recognizing that pneumonia treatment extends beyond prescribing antibiotics. Daily reassessment of oxygen requirements, clinical stability, laboratory findings, and the patient's ability to maintain oral intake should guide decisions regarding antibiotic duration and discharge planning, rather than solely relying on a predetermined treatment course. Although community-acquired pneumonia had become a leading diagnosis, I knew it was important to remain systematic and confirm the diagnosis while continuing to evaluate for other potentially life-threatening conditions, which is what the ED would provide. The first priority would be for them to obtain a chest x-ray to identify focal infiltrates or consolidation consistent with community-acquired pneumonia. Imaging remains the standard for confirming pneumonia and helps differentiate from other causes of acute dyspnea, such as the PE or pleural effusion. Laboratory evaluation would include a complete blood count with differential to assess for leukocytosis or leukopenia, as well as a comprehensive metabolic panel to evaluate renal function and electrolyte abnormalities, and hepatic function prior to initiating certain medications. Because older adults frequently become dehydrated during acute illness, I would also review serum glucose and magnesium levels and obtain a serum lactate if I were concerned for sepsis or tissue hypoperfusion. If the patient met criteria for severe community-acquired pneumonia, blood cultures would then be obtained prior to antibiotic administration. Although treatment should never be delayed while awaiting results, sputum gram stain and culture may also be obtained when a quality specimen is available, such as when in the hospital, or when resistant organisms are suspected. Viral testing for COVID-19, influenza, and RSV would also remain important because co-infection is possible and the results may influence the isolation precautions while inpatient or any antiviral treatment decisions. Given the history of AFib and complaints of pleuritic chest pain and dyspnea, I would assume they would also obtain an EKG and place her on a continuous cardiac monitoring. Troponin would be appropriate if MI or right ventricle strain were suspected, and BNP could also help differentiate pneumonia from acute decompensated heart failure if uncertainty remained. Even though pneumonia was my leading diagnosis, PE had not been completely excluded. And before ordering additional imaging, I would hope that they would reassess her clinical probability using validated tools such as the Wells criteria, while recognizing its limitation in anticoagulated patients. Because she was already taking Eliquis, a negative D-dimer would be less reliable, and if clinical suspicion remained elevated, a CT pulmonary angiography would be preferred diagnostic study after confirming the adequate renal function. I would also carefully review her anticoagulation adherence, dosing, and potential medication interactions, as breakthrough PEs, although uncommon, can still occur. Finally, because confusion was one of her presenting symptoms, I would continue evaluating for her other potential contributors to delirium, including metabolic abnormalities or alternative infection sources such as a UTI, if clinically indicated. This hospital comprehensive diagnostic approach would not be possible outpatient, but it does ensure that serious alternative diagnoses are not overlooked while confirming the most likely cause of the patient's presentation. Although transferring the patient to the ED marked the end of my immediate outpatient management, it certainly did not mark the end of the family nurse practitioner's role. One of the most valuable aspects of primary care is ensuring continuity across the healthcare settings, particularly for older adults hospitalized with acute illness. Following transfer, collaboration with the emergency medicine teams is essential to communicate the patient's presentation, baseline, differential diagnosis, and outpatient findings. If hospitalized, respiratory therapy would assist with oxygen managing, pulmonary hygiene, and monitoring respiratory status. Pharmacy consultation may be valuable to review potential drug interactions, optimize antimicrobial therapy, and clarify the patient's reported penicillin allergy. Because her allergy consisted only of a childhood rash without features of immediate hypersensitivity reactions, former allergy evaluation after hospitalization and recovery may allow future use of first-line beta-lactam antibiotics and improve antimicrobial stewardship. If the patient's clinical course became complicated, failed to improve, or as expected, or if resistant organisms or atypical pathogens were suspected, consultation with pulmonary or infectious disease specialists would be appropriate. Prior to discharge, case management would evaluate the patient's home environment, transportation, medication, affordability, and available caregiver support to ensure a safe transition back into the community. Patient and family education begins before the patient even leaves the clinic. I would explain that although community-acquired pneumonia is my leading suspicion, additional hospital evaluation is necessary because conditions such as PE cannot yet be excluded, and her hypoxia and altered mental status indicate a higher level of illness. I would also review warning signs that require immediate medical attention, including worsening shortness of breath, persistent fever, and increasing confusion, chest pain, inability to tolerate fluids, or any new decline in functional status for the future. Perhaps the most important outpatient intervention is the transition of care visit. Current evidence supports scheduling this follow-up after hospitalization within 7 to 14 days, with many high-risk patients benefiting from evaluation within the first week. During this visit after hospitalization, my priorities would include completing medication reconciliation, reviewing the hospital course, confirming appropriate completion of antibiotic therapy, and reassessing symptoms, oxygenation, hydration, cognition, and the patient's ability to safely perform activities of daily living. I would also evaluate for complications such as recurrent infection, medication adverse effects, persistent hypoxia, or post-hospital functional decline. This visit also provides an opportunity to return to the focus of prevention. Once the patient has recovered from her acute illness, I would review her immunization history and complete the recommended pneumococcal vaccination series according to the current CDC guidelines. Because prevention is cornerstone in primary care, I would also reinforce annual influenza vaccination, updated COVID-19 vaccination when appropriate, smoking avoidance, healthy nutrition, and early recognition of future respiratory symptoms. Cases like this remind me that successful treatment of pneumonia extends far beyond prescribing antibiotics. The family nurse practitioner serves as the coordinator of care across the entire continuum, from recognizing the need for hospitalization to facilitating communication between providers to ensuring safe transition home and reducing the risk of preventable readmission. The continuity of care is one of the greatest strengths of an advanced practice nurse. One of the strengths of family medicine is adapting evidence-based care to each patient's individual circumstance. If the patient were pediatric, management would change considerably. The microbiology of community-acquired pneumonia differs significantly in children, requiring age-specific antibiotic selection and weight-based dosing. Additionally, recurring pneumonia in a child would prompt evaluation for congenital airway abnormalities or immunodeficiency. If the patient were an older, frail adult, although this patient is already 72 years old, management would become even more conservative. Frailty increases the risk of delirium, falls, aspiration, prolonged hospitalization, and functional decline. In those patients, physical therapy, occupational therapy, nutrition services, and early discharge planning would become even more important as antibiotic therapy. Another differential diagnosis worth considering is aspiration pneumonia. Although this patient denies dysphagia, her confusion, advanced age, and acute illness increases aspiration risk. Depending on imaging findings or clinical deterioration, aspiration pneumonia could alter antibiotic selection and swallowing evaluation. Social detriments of health are another important consideration. If this patient had limited financial resources or transportation challenges, care coordination would become essential. The nurse practitioner should involve social work, assess medication affordability, arrange transportation to follow-up appointments, and ensure access to prescribed antibiotics and home support. Finally, cultural and language differences can significantly affect communication and treatment adherence. Professional medical interpreters should always be used when language barriers exist. Rather than relying on family members, using plain language, culturally sensitive education, and the teach-back method help ensures patients' understanding and promotes shared decision-making. These interventions improve adherence and ultimately lead to better clinical outcomes. This case highlights several clinical pearls that extend beyond the diagnosis of pneumonia. First, older adults frequently present atypically. Rather than high fever and severe cough, they may initially present with confusion, weakness, decreased appetite, or functional decline. Recognizing these atypical presentations is essential for timely diagnosis. Second, it is important to avoid premature diagnostic closure. While community-acquired pneumonia became the leading diagnosis, the patient's pleuritic chest pain, hypoxia, and previous history of DVT required continued consideration of PE until it could be confidently excluded. Third, clinical prediction tools such as the Curve 65 should complement, not replace, clinical judgment. This patient's score supported hospitalization, but her hypoxia, confusion, and inability to maintain oral intake independently also justified transfer to the emergency department. Another key takeaway is the importance of evaluating reported penicillin allergies. Many adults who report childhood rashes can safely receive beta-lactam antibiotics after appropriate assessment, improving antibiotic selection and supporting antimicrobial stewardship. Finally, this case reinforces the vital role that we have as family nurse practitioners beyond diagnosis and treatment. Effective transition of care, management, medication reconciliation, patient education, vaccination review, and addressing social detriments of health all contribute to improved recovery and reduced hospital readmissions. The NP serves as the bridge between acute care and long-term health maintenance, ensuring continuity of care across the healthcare continuum. This case serves as a reminder that successful management of community-acquired pneumonia extends beyond selecting the appropriate antibiotic. It requires thoughtful clinical reasoning, recognition of life-threatening alternative diagnosis, evidence-based decision-making, and coordinated transitions of care. As future family nurse practitioners, our responsibility is not only to diagnose and treat acute illness, but also to advocate for continuity of care, preventative health, and patient-centered outcomes. Thank you.